The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Dr. Dennis Birnbaum, and this is Cancer Update, a short walk through a long journey. The call-in number here is 972-445-0770, and the toll-free number is 877-272-5226. Joining me this Friday, as in the past, is Ms. Tina Withrow, the patient navigator for Texas Hematology Oncology. And if you wish to reach our office, you can reach that at 469-453-5500. Tina?
Good afternoon, everybody. I want to welcome everybody to the show and hope you are staying cool out there. The traffic was much better today, so Dr. B and I both are here. We've had an interesting week in dealing with cancer for sure. We've had lots of new patients, and it's been very interesting. It seems like everybody has thought that they had something going wrong in their body, but it turns out that their physician or physician assistant kind of dismissed their symptoms. So, Dr. B, can you just kind of expound on that, on what to do if you go to your doctor and, something just doesn't seem right, or something within you is saying, I really have a bad feeling, because you talk about listening to your gut, listening to your body. So I really want to know, because I think the public needs to know how they can be better educated about this, so that, as we know, cancer can be caught early, that you have a better chance for survival.
Well, in our profession and what we deal with, it's a little difficult, as in the general population. Very few people come to us who already haven't been diagnosed with something. We try and make sure that the patient goes back to their family doctor. They don't need to come to us for all their other problems, but as it has over the years, that's usually what happens. We end up taking care of the patient. A lot of the family doctors just don't want to get involved. They think everything, once they're diagnosed with cancer, then they think any other problems they have has got to be related to the cancer, even though most of our patients come with other comorbidities, be it from degenerative arthritis or lupus or diabetes or heart disease or hypertension or lung disease or asthma or emphysema, on and on and on. We try, as I mentioned previously, to send the patients back to their family doctor to make them part of the team. But I've learned over time in dealing in oncology that the patient knows really better than the doctor when they've got something wrong. They can sense it. They can tell what was wrong before they started chemotherapy, before they started radiation, and they know if something is not a real ache and pain. They know if it is not a pain that they've never had before, and they need to get an answer. That's really the crux of it all. They just want to have somebody give them a legitimate and honest answer, and not just kind of shove them under the carpet. One
of the things, I tell you all the time, a woman's sixth sense or a woman's intuition. And I think we all have that within us. But I think one of the things that we do is we feel that because a physician has gone to medical school, we might feel intimidated by the knowledge that a physician has. But I think that we've got to listen better to our body and listen better to what we don't necessarily know, but we do know. If we're really thinking about it, if we really, at 2 o'clock in the morning, it's really bothering you, I think that you really need to get that checked out. Someone here at the station, was really, really concerned, hadn't had a mammogram, and called me on the phone and said, Tina, I just am not real sure. I have to pay out of pocket for that. Do you think I can wait? What should I do? And in talking further with her, it was a real concern for her. She really had some thoughts. She has had family members that have been affected by cancer. So we talked about it and found a really good place that does a great job and is very professional at a reasonable price. And I'm glad to say that she told me today that she is all clear, and she probably doesn't have to do that part for another year. So I think we've got to listen real close to our bodies and really team up. And if your physician isn't teaming up with you, then you need to think about either talking to that physician and saying, I'm just not feeling the connection that we have, or your staff. I'm not feeling connected to your staff, or you need to go seek other opinions.
My answer to that is, unfortunately, in this economy, the economy drives the interests of the patient. A lot of patients, like you mentioned, are afraid to have anything done because of the cost. Some may not have insurance. Some may have the insurance that is very limited, and they got to get it pre-certified and got to get it approved, and they're afraid of calling because it's going to cost an enormous amount of money. Now, I'm a firm believer, and I think you're aware of this, that I don't care if you got a problem at 11 o'clock at night, or 2 o'clock in the morning, you need to call your doctor. Either that or go to the emergency room if it's really bothering you that much. And if your doctor just sloughs it off, you need to find a new doctor, because this is your health. And in our case, we deal with cancer patients. And if you're not getting the attention that you want from the oncologist you're going to, get another oncologist, because I think there's over 400 in the Metroplex. And I'm sure somebody out there will be willing to answer your questions or take a more attentive notice of you and be more responsive to your needs. And every patient's going to have different anxieties, different things that trigger them off. And if you're not willing to deal with that, then either you're in the wrong profession or you need to tell that patient to go someplace else.
Well, let's expand on that a little bit, because we have a patient, and he has a lovely wife, and I'm going to say her first name is Jamie. She's what I call the face of the new type of caregiver or survivor. She's the person who's very intelligent, very organized, goes out on the internet, really wants to know what's happening, wants to know, to get into a rhythm once her spouse, friend, whatever I'm going to say, has been diagnosed. And I think the consumer is much more intelligent than they used to be. It used to be you went to the doctor and you did exactly what your doctor said, or if he didn't say, you just kind of guessed and waited till your next visit. But I think now, today's consumer, and with the internet, and with blogging and with groups and Facebook, you really can become very well informed, and it's an easy way to put something out there that you can, find out if you have a problem. There's a great website out there. It's called Patients Like Me, and very interesting. It was started by a man whose two brothers, I think, whose brother had Lou Gehrig's disease. And they started it so that patients could really speak with each other about what was happening with the disease, what was happening in the drugs that they're taking, what was happening in their doctor visits, and so on. Well, it grew so fast that now pharmaceutical companies are looking at the outcomes from Patients Like Me. So the internet highway has really changed things for us. And one of the ways that our listening audience can make a difference and get in that talking with each other and connect with survivors, our website is Texas Hematology Oncology PA. That's the name of our group, but you go to THOC PA, and that'll take you to our website. And then you click on Facebook. That takes you to Facebook. And what we want you to do is we want you to like us on Facebook. And we're putting that out there for everybody. Please go to that website and like us on Facebook, and going to be a lot of new things. Dr. Birnbaum's going to be putting articles out there, things out there. So I want you to pay attention to that, because we are on the information highway for sure. We have a call.
Hello, this is Dr. Birnbaum. Can I help you?
Hey, Doc, it's Darcy.
Oh, my God. The
My
man of the
hero.
hour.
Hey, Dars.
How are you, pal? Hi, Tina.
How have you been, Darcy?
I've been doing great. Just wonderful. Thanks to you.
For the listening audience, this is Darcy. He is the sweetest. I have to tell you, Darcy, I know you're married, but I am in love with you. I can't help it. I can't help it. Darcy and I, we tell each other that we love each other, and we do, even though he's married and I'm married. And that's because how long ago did we go to war together?
Oh, about 2.5 years ago.
About 2.5 years ago, Darcy was diagnosed with, I'm going to let you answer that, Darcy.
Throat cancer to start with.
Throat cancer. Well, throat cancer is very near and dear to my heart, because my sweet sister had throat cancer many, many years ago. And so Darcy came to us, and he was just delightful from the moment. We liked him right away, and then we loved him shortly thereafter. And Dr. B, can you just speak to the nature of what Darcy had done and how he's doing? I mean, we don't want to go into details, Darcy, but I'd just really like the listening audience to know that.
You really want me to tell them everything, Dars?
Absolutely not.
Darcy and I had a very difficult time initially, because he had some horror stories from friends of his that had gone through similar type of treatment. And he virtually ran the show. And he agreed to the chemotherapy, but did not agree to the radiation therapy, which is part of the total protocol. And we tried it his way until it came back, I think, within 8 months. And then he tried it my way. And now he's in complete remission, and he looks great. And he's talking and eating and drinking, and I can't shut him up. But he's a fine young man. He's about 85, 90 years old.
No.
Darcy.
You know,
Dr. B,
75.
I mean.
He looks like he's about 50. He's in great condition. And he's just a gem of an individual. He's done a lot of help for us with our patients. And he has a product. I got to tell you something, people. He gave me this product to try out, and I've got horrible knees. Mainly before I lost any weight, I just had too much weight on my knees. It was bone to bone. I had a lot of problems with my shoulder. And I'm going to let him tell you about this product. But I did try it, and I'm not here to push anything for him. But even the masseuse that comes out that I use about 4 times a month tried it and said it's just fantastic. It's a golfer's regimen. It's on like a band roll type of product, and you roll it on your joint area, your knees or your shoulder. And I'm telling you, the relief is phenomenal. I'm really serious. I'm not just pushing it because it's Darcy. It is really good. And for anybody out there who's a golfer or who plays tennis or even jogs, you need to seriously consider this. Darcy, tell me a little bit about it.
Well, it's a wonderful product. It's pretty new. It's been in Australia for about 7 or 8 years, but it's just started coming to this country about 2 years ago. And it's called Golf Pain Away. In Australia, it's Elmore oil. But it's all natural products. It's a variety of olive oil, Australian tea tree oil, eucalyptus oil, and vanilla bean. Now, this is a maturation process. It takes about 8 weeks to finish, and it's quite a process. And it's the only thing I've ever found that actually works and won't stink you out of the house.
Oh, I agree. I'm telling you, he gave me samples of it that are like an alcohol swab, and then he gave you the ones that are on a roller ball in a a container and you just roll it on, and it is fabulous. And you're right, it does not have a foul odor whatsoever.
I happen to like the smell of it. The little packets that you gave us, I've given out to patients, and they really find, cancer pain is really a tricky thing. And, not all cancer patients, not all pain is cancer. But when you have cancer, you think every pain is cancer. So this has been really, really nice to give to the patients, and they've been able to get relief. I have a knee that gives me trouble sometimes because I'm on my feet a lot, and it really helped me a lot. And I like that it has all the natural oils and everything in it, and there's no chemicals in it. For me, that's a really big thing.
More than that, there's no narcotics.
I have a very good friend that can't get out of bed in the morning until he rubs this on his shoulder.
You're right.
Yeah.
Darcy, how have you been doing?
I've been doing wonderful, Doc. My weight is perfect. I'm 178 pounds. That's down from 240 when we began, and it's holding right there. I eat everything in the world.
No problem swallowing?
No problem swallowing. Drinking a little wine, a little red wine, no problem there.
So going through
burned me something terrible.
Going through the chemotherapy and radiation, now in retrospect, it worked for you and it wasn't as scary as you thought.
Absolutely. But the horrendous things that I saw with these other friends of mine, a couple of them passed away, and that's why I fought y'all. To start with.
Well, it was a good fight.
Darcy,
Yeah.
I call what you had was the cancer terrors. And, we do base that. My mother, when I was a young girl, my mother had cancer, and she was in a lot of pain towards the end of her life. And so I thought all cancer patients, if they had end-stage disease, number one, never lived, and that I thought they lived out their days in pain, and that is so not true. One thing before you go, Darcy, because I want you to tell anybody out there listening who's been newly diagnosed, what can they do for themselves in fighting the cancer? Because you know how to do it right.
The biggest thing, Tina, is just be positive. You have to be upbeat about it. I never for a moment thought that I was not going to win.
And that makes a big difference.
You have to be upbeat about it.
Well, you've got the great prescription for it, because those that certainly don't do as well as you have, Darcy. Thank you so much for being on the show. I love you. And
thank you. I love you both.
Take care, Darcy. Have a good weekend.
You may love us both.
You're my hero. So.
Darcy, you may love us both, but you love me more than him, right?
Absolutely.
Oh, good. Good. Bye, honey.
Jesus.
Bye.
You're not supposed to say that on the show.
Oh my God.
Okay, Dr. B, here we go. I'm loving all of you out there that are sending me emails. I love corresponding with you. Don't forget to like us on Facebook. Go to the THOCPA website, click Facebook, and like us. And I want to say that I'm really happy with those that are corresponding with me out there, and your questions. Your questions are so good and intelligent, and just keep them coming. I've got some that we're going to talk about with Dr. B. One of them says, "Hi, Tina and Dr. B. Love your show. My husband had a serious accident at work 5 years ago and was put on warfarin for a blood clot. He goes into his doctor only every 3 months. Does he still need to be on this drug? He believes that by taking the warfarin, he is saving his life." And this is from Billy in Sherman, Texas.
Okay. There are a lot of reasons why people develop DVTs, deep vein thrombosis. Probably from the accident, he had some type of interruption of the circulation, meaning stasis, S-T-A-S-I-S. And depending on whether it was a mechanical obstruction or whether it was a vascular obstruction due to a clot, you usually want to work them up, generally make sure they're not part of a hypercoagulable state, that they're not part of that population that overclots anyway, whether you had the accident or not. Once you've eliminated that and the patient's being treated for the thrombosis, they're initially probably going to put on either unfractionated heparin are low molecular weight heparin. In other word terms, like heparin is a blood thinner. The low molecular weight heparin, otherwise known as Lovenox, you give the shot either once or twice a day, anywhere from 7 to 10 days to start the anticoagulation, to start the breakup of the clot. And while that clot is starting to break up and hopefully preventing future clots, and we'll go into the problem because I know this disease well, my father died from it. The thing you got to worry about is if you have a clot any place, but mostly in the lower extremities, that clot can dislodge, go up the vena cava into the lung, lodge in the lung and cause a pulmonary emboli, which is a massive clot in the lung, and it will stop you from breathing, which is what caused my father to die. So one of the things you do is once you immediately get them on the anticoagulation therapy, you make arrangements to have a venous filter put in place. That's a filter that's put in the cava.
How long has that been around?
Oh, God, easily 20 years, if not longer. And you have a filter put in place in order, it's more prophylactic, preventative, and it's like a little mesh sheath that's put into the cava that prevents clots from the lower extremity going up. Now, once you do that and you start the anticoagulation therapy, you slowly convert over off of the sub-Q or continuous infusion IV heparin or Lovenox sub-Q to oral therapy, which is Coumadin or warfarin. And you have to monitor them with a PT-INR. And the range of the PT-INR is usually between 2 and 3. If you get above 3, you either want to stop it for a little while until it comes back down, because if it's too high, you'll bleed. If it's too low, you're not getting well anticoagulated, you're not breaking up the clots. Why this person is on it for 5 years, unless they have repeated episodes of clots, I probably, in somebody that has an accident like this, you usually put them on the initial heparin or Lovenox for 7 to 10 days, and then you convert about day 8. You start the Coumadin so they overlap. Then you stop the heparin or Lovenox and continue the Coumadin. You'll monitor their PT-INR twice a week for like the first 2 to 3 weeks. Then you go once a week for about another 2-3 months. And then you go every other week for about another 2-3 months, and then maybe once a month you'll do the testing. I don't do anybody any less than once a month because Coumadin can be a dangerous drug. There are other drugs, for example, antifungal drugs. If you give those to somebody on Coumadin, it can prolong your PT-INR and it can cause bleeding. So I'm not sure. I look at every 3 months doing the testing. I'm not sure I would agree with that. But I go back to the statement I made a while ago. The duration of treatment, if you go back and do Dopplers of the extremity and the clots are gone, there's no reason. Once the clot is gone, I usually keep them on for maybe another 4 to 8 weeks, and then I stop it, and I'll convert them over to aspirin. And it's usually Ecotrin and enteric-coated aspirin. But I won't leave them on the warfarin or the Coumadin.
Because there's dangers in being on that too long?
Well, there's no need to be on it. That's the main thing. You know, there's always danger in any drug you take, but the main thing is that you don't want to leave them on it too long, and you can convert it over I usually put my patients on aspirin because that's also an antiplatelet factor.
Okay, thank you so much for that. The next question, this comes from Jana in Garland, Texas. I have heard that PSA is not a good test for prostate cancer. My husband is 78 years old. Our PCP told us that he really doesn't need it, and I am worried.
Well, what do you want me to say?
Does the 78 years old have something to do with that?
That's what I'm wondering about. Is he saying that because the gentleman is 78 years old, and a lot of the urologists and a lot of GPs, somebody came down with prostate cancer, I'm not sure how they would approach it. Again, we had this discussion last night at the volunteers dinner at Dallas Medical Center was the question about when is it too old to treat a patient. When I was at MD Anderson, age is not a criteria. Even today, MD Anderson does not use age as a criteria. What you use is the condition of the patient and the comorbidities of the patient to dictate whether or not you're going to treat the patient. If I have a man 78 years old that's got prostate cancer and it's an early stage, I'll put him on some Lupron and Casodex and give him radiation. And I can guarantee you the cancer won't kill them before something else does, but at least they won't have problems with their prostate cancer. So I don't know if her doctor is saying this because he's 78 or if he's just saying he doesn't believe in the PSA. And if it's because he doesn't believe in the PSA, then I don't think he knows what he's talking about because, yeah, there's a lot of controversy out there right now, even in all the oncology literature, about whether or not the PSA is the best test and how reliable it is. But for me, until they come up with something different, we used to have the prostatic acid phosphatase, the PAP test, that in combination with the CEA, the carcinoembryonic antigen. And then Hybridtech Corporation came out with the PSA test years ago. I still use it. I still find it to be extremely effective. It's a good guideline. The other best guideline is the patient themselves, the clinical presentation of the patient, and also seeing what the patient, whether they got metastatic disease or not, and following the patient. If you get a patient that has a PSA at 563, and you put them on Casodex oral medication, and then you give them their Lupron shot, and the next PSA is somewhere around 200, then you know something's working. And then the next PSA is around in the 60s, then you know something's working, and you use that in combination with radiation. I don't think in all of the cases the PSA is ever going to reach normal. There are a lot of the majority. That
was going to be my next question.
Yeah, a majority of the patients that I treat, I would say maybe 75% of them never get down to the normal range. About 25 to 30% will get in the normal range. But it's a good guideline. It is not the only guideline, but it is an excellent guideline to help you monitor your patient.
And the PSA isn't the only thing when you're looking at somebody with that type of cancer. The PSA isn't the only thing you're looking at. You're, like you just said, you look at the PSA as just one thing that you're looking at with that patient. And I think that's a good standard in all of oncology. You don't rely on just one thing, correct?
No, but for a GP to say that they would not recommend doing the PSA, I just think that's wrong. I don't know where he's getting his information from, and I don't know how many prostate cancer patients he sees.
Right, but you know that we hear all kinds of stuff out there. That's the purpose of this show, to separate fact from fiction. So that was a really good question. The next one comes to us. My wife lost her voice box to throat cancer. Now she is having trouble swallowing. They say this is caused by radiation. Could you please explain? That's from Raphael from Waco, Texas.
It's a pretty accurate statement in most instances. If their throat cancer, I don't know what treatment they got. If they got, like Darcy did, chemotherapy with radiation sandwiched in between, majority of these people are going to get severe mucositis, stomatitis, and dysphagia. Some of them even need to have feeding tubes put in because of the enormous amount of swelling that occurs. You can't swallow. And once they go through the treatment and it's all over with, majority of the swelling goes away. But a lot of them have the residual effect of the edema caused by the radiation. Now, I would be a little bit concerned here, because in my experience, in the patients I have seen, usually within 6 months off of treatment, they're back swallowing, doing well. Darcy's your best example. And he had, a real commando type of approach in his chemotherapy radiation. He almost had twice because of our disagreement. He didn't want to do it the right way. He wanted to do it his way. So we had to double up and go back again within an 8-month period of time. Thank God he did well, and he's doing well right now. And he's just recently we staged him. He's totally free of disease, and he's in ED. But in general, you're going to have these side effects. So if I have a patient come back to me now this, and I assume this is a long time after she's had her treatment, and she's still having problems swallowing, I would get myself either a good ENT doctor or even a gastroenterologist. I want to do a good indirect and direct laryngoscopy to review the tissue, to look at it real well, and maybe even do some random biopsies to make sure it's not tumor that's come back. And number two, I would want to get a GI doctor to do an upper GI endoscopy to look down the esophagus, because don't forget, where this person had their chemo and radiation is right next door to the esophagus. So no matter how expert your radiation therapist is, there's going to be tangential radiation that's going to hit your esophagus. And the esophagus is a very friable tissue, a little bit more friable than the trachea is. So they may need just simply to go scope them and dilate them. They may just have a stricture in there from the previous treatment and radiation.
What do they do when they dilate that?
They start off with the smallest tube they can, almost a pediatric tube that goes down into the esophagus, and they get to the point where the narrowing is, the stricture is, and they balloon it up, and it just stretches the esophagus. They do it very slowly because you do not want to rupture the esophagus.
Is that
Same
a painful
thing with the trach. No, from the people I've talked to, they said, first of all, you're anesthetized. You're under.
Okay.
Most of the people I've talked to said they have really no bad feelings. They're a little hoarse after the procedure itself, but within 24 hours they feel better, they can swallow, and things are much better.
So you see that happen sometimes in your
I've
patients?
seen my brother, who does not have cancer, when he was much younger, because he's very old now. I mean, my brother's ancient. I mean, it's just Methuselah.
Boy. I hope he's listening.
And he had some problems with esophageal stricture, and he got dilated, and he didn't seem to have any side effects from it. You know, he's still talking, even though I regret that, but he is still talking and swallowing.
That's got to be a horrible feeling, though, to have something caught like that, or not be able to pass something like that. I can't imagine what that.
I know that feeling personally.
And yes, you've had that. I've seen you suffer from that a couple of times, and I thought at one point that we were going to have to give mouth to mouth or something. I think I got 911 in my phone real quick, so that's got to be a terrible feeling.
But if I were that person and it's this far past the time they've had treatment, I'd be a little suspicious. I'd like to get it investigated, make sure there's not recurrent tumor. And if they're truly having problems swallowing, I would see if it's just a stricture and get it dilated.
Okay. I have a final question for you, Dr. B. In today's medical arena, do economics drive treatment choices for patients? And if they do, what can I do as a cancer survivor to make sure that I get the best treatment for myself or my loved one? I thought this was an excellent question.
There's no question, and we know what's going on right now with Obamacare.
They're supposed to make a determination this next week, aren't they?
Could be today, could be any time soon. It's going to be before July 1st, I know that. Excuse me.
Well, a lot could change with the coming of the election, and part of me wants it done and over with so we can move forward from it. It seems like every time there's an election year, everything gets kind of put on hold while everybody kind of does the for and the con and everything. But the bottom line for me as a navigator is something has to be done. Everybody talks about the cost is too high. In oncology, what I'm seeing in the journals that come across my desk that frustrate me is everybody talks about the high cost of these drugs, which I agree. If the cost of the drug is too high for people to afford and there's no profit margin, because we've seen the profit margins shrink to where there's no profit in drugs for physicians, and you got to make some money because you got to pay the bills, then why are we letting pharmaceutical companies do it in the first place? There's got to be some balance here. So for me, I don't...
Well, they're paying them billions of dollars. There's some people that feel, in answer to your statement, if there's not the margins and the drugs cost so much and it costs billions of dollars to do the research to develop these drugs, I think it costs something like $6 billion to develop Avastin. In that case, a lot of people feel that to use these drugs, you should only be given treatment at a university setting. It should not be in the community cancer centers, in the community practices, because it's just too price prohibitive. But going back to your question, there's no question that economics play a very big part in determining the outcome in the lives of many cancer patients. I can't talk to pulmonary or cardiology or kidney patients. I have a lot of friends that are dialysis physicians, nephrologists. But I know this. I mean, we had it today. I had a patient that needed to get a PET scan, and their insurance will not let them have it done. They want them to only get a CAT scan. And yet there's a report on the chart, because we've already done the CAT scan. And the radiologist recommends to discern the difference here, we need a PET scan, and I recommend that you get a PET scan. So I am following the recommendations of a board-certified interventional radiologist that's telling me to get a PET scan. And I send that with the request to the insurance company, and they deny it. They feel that it's not necessary. So then I've got to take the time to do a peer-to-peer with a doctor who represents the insurance company, who doesn't know diddly swat about oncology, and he's going to make a determination on the life of this patient and on the treatment of this patient, because it makes no sense for me to continue giving this treatment if it's not working. I mean, I think it's working. It appears to be working, but I don't have microscopic eyes.
What's the cancer type?
It's a lung cancer, and with mediastinal lymph nodes and other lymph nodes elsewhere, and the person has responded real well, but we need a PET scan.
Doesn't Medicare pay for a PET scan? They
only allow so many per year, and
I see.
This is a private insurance, and rather than discuss which private insurance it is. So your question is, does economics play a role? There's no question it plays a role. Every quarter, we get reports from the various drug manufacturers, or from Oncology Supply or AmerisourceBergen, and they will show how the margins have changed in the usage of certain drugs, Taxotere versus Taxol, carboplatin versus oxaliplatin versus cisplatin, and a lot of oncologists, because you're right, you don't want to lose money.
You can't afford to do that.
Well, you got to pay bills. And to go along with that, you have to make a determination. And sometimes you have to change your drugs from cisplatin to carboplatin or maybe to oxaliplatin. And unfortunately, certain tumors, the research done on the tumor was only done with either carboplatin or cisplatin. But if they are cost prohibitive, then you're left with oxaliplatin, and there's no research out there, let's say, for X disease, having tried it with oxaliplatin. So number one, you may not even be approved. Number two, you can't give it to the patient unless you put them in the hospital, because they have different margins than you do, or the patient's going to have to make up the difference. So yeah, it's very cost prohibitive as to what drugs that you're going to use on the patient. It's not only the drugs you're going to use, but it's the studies you have to do, the x-rays you have to do, because somebody's got to pay for it. You don't want to sit there and guess whether or not the patient's responding or not. You've got to know whether or not the patient is responding to your therapy. Otherwise, you either need to stop therapy or go to a different therapy. And the only way you can make that determination is by radiographic studies or tumor marker studies or studies that are out that will help you make that determination. And those cost money.
What can I do as a consumer if my loved one has cancer and I really think I'm in a situation where economics is playing a role in my loved one's care? What can I do as a consumer? Do I say to the doctor, do I just come right out? Do I say, are economics playing a role here, Dr. Smith or Jones?
Well, if I were a patient, and God forbid I was diagnosed with cancer, I'd want to sit down with my doctor and ask him, I want to know what my disease is, what stage is it, what is my 3-year and 5-year survival rates, what kind of treatment am I going to need? Am I going to need chemotherapy, surgery, radiation therapy? What kind of therapy am I going to need, and can you give me an idea of the costs? Now, if he has any semblance of decency about him, he'll be honest. And if he doesn't know, he'll direct him to somebody who would know. And hopefully, and we know, you and I both know, that most of oncologists don't have patient navigators. They don't have somebody who is financially has the wherewithal to present to the patient or their family the answers to those questions. And a lot of people, they get their insurance. I've got Blue Cross Blue Shield, or I've got United Healthcare, and they don't understand what their benefits are. So they need somebody to explain that says, look, you've got $2,000 deductible, and this is what your copay is, and this is how much out-of-pocket expense you're going to have. People don't know that. And let me tell you, when they get the big C diagnosis, they really don't know about it because they don't care about it. They're focused on only one thing. Is my wife, my son, my husband, my grandparents, are they going to live? They're focused on treating their family member, and they lose sight and even interest in how much of the deductible it is or how much the copay is. And they have to understand that the doctor's not going to treat you for free, and you may not be in an area where you can go to a Parkland hospital, and you may want to go down to MD Anderson, which is very acceptable if you're a Texas resident. So you have a lot of options there. But make sure, I always tell the patient, every time they're in my office, when you leave here, if you got a question, write it down. And if you want to call me, here's my card. You can call me 24/7. I'm on my cell phone all the time. You can call me at night. I'm watching TV. But get your questions off your mind. Get them off your chest, because it does not do you any good just having these smoldering questions that are unanswered. And if you got problems with where you're going and what you got to do and what the cost is, I will direct you as to where to go. You don't want to shove this off to do it next week or the week after. You want to attack it, every aspect of it. You not only want to attack the disease, you want to attack the problems of finances and insurance, and how are you going to organize all this with your everyday duties. Most of my patients, somebody there works. Somebody there has to drive the patient around. So they got to readjust their schedule. So if you're not willing as a doctor or as a patient navigator to work with the family and sit there and listen to their complaints or their problems or their anxieties, then you're in the wrong business. Now, turning it around, if I'm the patient or if I'm the caregiver, or if I'm the family member, you have got to sit down, take a deep breath. Okay, we've got cancer. Let's organize this. Let's get to the right doctor. Let's get to the right people, and let's ask the right questions. And sometimes they don't know the right questions. And it takes somebody like you, Tina, or myself to say, look, I'm going to ask the questions that you should be asking because you haven't asked them yet. We've been doing this for many years, so let me tell you what you got to watch out for. And here's what your insurance plan is, Mrs. Jones. And this is what it's going to cost. And if you need help, we can find help for you. There are agencies out there, there are foundations out there that may be able to help you with your expenses.
The other thing is, just to add to that, I think it's an excellent response that you gave. Nobody at any time should be talking down to you either, because this is new and this is
frightening.
Why?
What's the reason for that?
Well, there is no reason. But I hear from people in my cancer ministries and the things I do throughout the Metroplex that sometimes people are kind of shamed when they ask what is determined as kind of a silly question. But you never should be a place where your questions are deemed silly or inappropriate. Because
let me interrupt you there. Let me tell you something. If a patient, and it doesn't even, I was going to say if you're recently diagnosed with cancer, forget that. I don't care if you don't have cancer. If a patient, it doesn't matter whether it's the most highly intelligent Phi Beta Kappa question in the world or a stupid question, it's a question that concerns you enough that you've thought about it and you want to ask it. If you are embarrassed to ask it, or if you are made to feel embarrassed by a doctor's office because you ask what they may think is a stupid question, or the doctor may think it's an unnecessary question, go to another doctor's office, really. You don't need, under this time of stress and anxiety, to be made to feel that way. You've got enough problems. You don't need to have your own doctor's office criticizing you or belittling you because of a question that you may think is important to you. Is not important to them.
Excellent. I really, really like how you spoke to that, Dr. B, because that's a really big concern in people's mind and how they can, get their loved one through this. And there's so many parts and pieces to the puzzle. And I think that we get really overcome by that. And I thought you answered that question really, really well.
We are going to take a short break. This is Cancer Update, a short walk through a long journey. Please come back and join us. We'll be back in about a minute.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
We're back, everybody. This is Dr. Dennis Birnbaum. This is Cancer Update, a short walk through a long journey. I'm here with Tina Withrow, patient navigator. The call-in number is 972-445-0770, and the toll-free number is 877-272-5226. Tina?
Yes, I want to remind everybody, if you are looking for answers to what's happening in your life in regards to cancer, you can go to thocpa.com. And you can also like us on Facebook. You click, after you get to the website, you click on the Facebook and you like us, and you will be receiving state-of-the-art information on treatment, protocols, new things happening in the world of cancer. Dr. B?
We're going to start putting information on the website, various topics that will come out. We get journals all the time that you don't get on the internet, and I'm going to try and put those on our website so that it'll be available to you. It'll talk about everything from new oral oncolytic drugs, the ideas of, is age a criteria for treatment? What are some of the treatments that are being used today for the older population versus the younger population? I'll bring things out there on nutrition that's coming out. And just turn into it and look us up on the website and on Facebook, and I think you'll find it most interesting.
Want to tell everybody, I had the joy of attending a luncheon called Let's Face It by the American Lung Association, and I want to remind everybody that lung cancer is out there and very active. The most shocking thing that this luncheon taught me is that lung cancer is really, really affecting women in a big way, and they are non-smokers. We have a call. Let's see if we can get that in before the end of the hour.
Hello, this is Dr. Birnbaum. Can I help you?
Dr. Birnbaum, this is Joe Weaver.
Hi, Joe.
I was diagnosed in 92 with prostate cancer. Well, not 92, 2002. And it was at the early stage. I went to one doctor. He said, we're going to wait and watch it. My urologist sent me to another doctor. He did a seed implant, and I am totally 100% cured. So I believe in the PSA and early testing for prostate cancer, and I want the whole world to know it.
I think I'm going to invite you. Why don't you come down the radio station? You can take over my position.
No, sir. You're doing a great, tremendous job.
Well, I appreciate your call, Joe. I agree with you 100%. I'm glad you are a perfect example of somebody who got a second opinion. When you found out that the second opinion proved that your first opinion was not right. I think people should do that. I think getting early prostate cancer taken care of, like Arnold Palmer did, and many of the golfers that are out there, and you hear about other people, you're the exact example of somebody who did the smart thing, got it taken care of, and you're disease-free, and you can go on with your life right now. And I think what you said is right. There's a lot of controversy on the PSA, but until they come up with something better, I think you're right. It's a good test to follow.
Joe, if I could follow up quickly on your comment, I think that we, as Americans, have to be very careful in what we let slide by at the expense of survivors. It's real easy for an article to come out and say that early detection costs too much, causes people too much anxiety.
Amen.
And, while I know that it is expensive, all it takes is one life. One life
That's
is
right.
precious. And I think we as Americans need to stand up and demand
Absolutely.
that early detection be there for us, because a lot of times we just stay silent about this stuff.
Sure.
And you are proof that it works, early detection.
My problem I have with this is that a lot of insurance companies won't pay for screening, which I think is the most stupid thing in the world, because, like you said, if you can catch one patient, early detection with screening, what that costs, those savings to not only the patient but to the insurance company, rather than waiting till it becomes advanced cancer, which is much more expensive, just substantiates the need for early detection and for having screening throughout the United States.
Something else.
I'm going to add one more thing.
Yes.
And 2 years ago, I was diagnosed with a bladder cancer. They went through 3 scrapings on my bladder, and with a BCG washout, BCG washout, and I'm clean and clear of that because they caught it early too. So,
well, Joe, will you keep listening to us and let people know about us, because we need people like you calling in and reminding everybody about early detection.
Absolutely.
Joe, thank you a lot for calling. Have a good weekend.
Thank you for your program. I listen to you every Friday.
Take
Thank
care.
you.
Bye-bye.
Have a good day and God bless you.
Thank you. Well, that was good. I think that's a perfect example of 2 points. Number one, the importance of early detection and the importance of getting a second opinion. Because I don't think if he had gone along with his first doctor and not done anything, he probably would have had advanced disease and maybe not even been here today.
I I watched last night. I tape all of the Dr. Oz's shows, and they had a thing on ovarian cancer, and Dr. Oz came to Grapevine Mills Mall and screened for free women. They were in droves. I thought it was very interesting when they did the video of the crowd. I spotted 3 of our patients in the crowd. I thought that was real interesting. And when you can stop and look closely at people's faces, there were 3 of our patients there. But they took women to raise awareness on ovarian cancer, and they gave people free vaginal ultrasounds. It was remarkable, the cancers they found. It was really remarkable. And I think we're going to talk, I talked with you earlier, Dr. B, about next week, talking about ovarian cancer. And so I think that's a really good topic for women.
I think 2 topics we'll talk about next week so everybody can be aware of this is, number one, we'll talk about ovarian cancer. And the other thing we're going to talk about, I know a lot of people see Good Day America and Robin Roberts.
Oh, Good Morning America.
Good Morning America. Obviously, I don't watch these programs. And her battle with breast cancer, and now she's got myelodysplasia. And we're going to talk about that. That was one of the questions asked last night at the volunteers dinner last night. We're going to talk about that next week. What is the association of this disease called myelodysplasia with the general population? And why is it she's so young and she developed it? And we're going to talk about why it's more prevalent in people who've been on chemotherapy.
You spoke last night to the volunteers at Dallas Medical Center, which is a quite intelligent group. I mean, they kept you on your toes. I loved that. But something else, Dr. Birnbaum, I've been asked, and maybe you can answer it now, but, Sheryl Crow's been in the news a little bit about having memory loss, and she has what's called a benign brain tumor. Mm. Can you just expound on what that is? Is that real common?
It's a space-occupying lesion. probably a benign meningioma can be treated with surgery is usually the treatment of choice. I don't know too many cases. There's no place for chemotherapy. Some people will go to radiation if they don't want the surgery, but surgery usually is the best treatment here.
Or they watch it or something.
Yeah, unless it's causing some neurological or speech dysfunctions or neurological dysfunction.
She forgot the words to a song she was playing, and she just forgot the words to the song.
She definitely needs, I'm sure she's had treatment by now.
Well, I think they said maybe they're watching it. I don't really know. I haven't really.
But what it is, it's just a space-occupying lesion. If you look at it on X-ray, it's like a tiny little marble. And it's pushing the structures of the brain and the very finite structures, the neurons and the dendrites and the nerve fibers. It pushes them, and when you start pushing them, things happen. Either motor dysfunction occurs or neurological dysfunction occurs. It's like if you have a bad splinter in your hand. You can't close your hand because if you do, the eschar or the swelling in your hand from that splinter will cause pain. So when you remove the splinter and the swelling goes down, you're able to move your hand. It's the same thing in the brain. When you have a space-occupying lesion in the brain, it's causing things to move around. And the synapses from point A to point B are not connecting, because something's blocking it, that benign lesion. It can, use a term loosely, it can become a malignancy in that it's not cancerous, but because of the damage it's causing, you term it as a malignancy. But basically, in simple terms, it's like a space-occupying lesion that's pushing things around and interrupting the nerve fibers. And rather than going to specifics of dendrites and axions and all that, they've got to remove it, because the brain is a very self-regenerating structure, and once you remove it, then it'll regenerate and the nerve fibers will come back.
Did this have anything to do with the fact that she's had chemotherapy or cancer?
Could be.
Could be.
For me, if this was a cancer patient, I'd want to make sure it's not a tumor. I'd do get a neurosurgeon to go in there and do a needle biopsy, because if that's tumor, I wouldn't even fool around. I'd get it out of there. I mean, it's the same thing that Lance Armstrong had when he had testicular. They removed it and took care of it all. We're near the end of the program. Is that correct?
Yes.
I want to thank you all for coming on board. Have a nice weekend. If you have time, watch the HBO program 41. It is a heartwarming program of George H.W. Bush, and it is worthwhile watching. Otherwise, you all be careful. Stay out of the sun. If you're in the sun, wear sunblock. Have a nice weekend.
Bye, everybody. God bless.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700, and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.